Cami Maddocks from the James Cancer Hospital, and I'm accompanied today by Dr. Pierluigi Porcu from Sidney Kimmel Cancer Center, Dr. Pamela Allen from Winship Cancer Center, and Dr. Jonathan Friedberg from Wilmot Cancer Center. And we're here today to have a discussion on the treatment landscape in diffuse large B-cell lymphoma and follicular lymphoma. All right, let's move on to our last topic, emerging treatment targets and kind of the ASH data. So we talked a lot about some of the, I think, the further along bispecifics. What about anything that you guys have seen maybe in earlier phase trials as far as looking at things to target, or maybe phase 1 studies, any treatments that anything you've seen, follicular or large cell, that you think is potentially of interest?
I mean, I think that at the preclinical levels, not even phase 1, but I mean, I'm following, carefully work that targeting pathways like, thinking about what to do with p53 null or mutated, which we know has a big impact on DLBCL. And MDM2, for p53, sort of the have p53 pathway on good, and PARP inhibitors. That's another class of drugs that I'm following and interested in. So I think there's a lot of there's a lot of very interesting pathways being targeted. We're just going to have to see, what the specific subsets of DLBCL that may apply to.
So I would say in addition to new agents, next generation approaches to our current existing agents have a lot of promise. There are data at this ASH meeting on pirtobrutinib, which is a next generation BTK inhibitor, which seems to have activity when the more conventional BTK inhibitors don't work, at least in CLL and mantle cell lymphoma. And as we're looking for roles of BTK inhibition in both follicular lymphoma and large cell lymphoma, I think it's very promising to think that pirtobrutinib or drugs like that may have a role.
I'll be excited to see more about the allogeneic CAR T cell, and then outside of therapies, ways to predict relapse, so ctDNA and other methods to monitor patients for relapse, I think will be interesting as well.
So that sequences nicely into the next question. What data here at ASH, and we're just kind of starting to see data this morning. So, but just looking through abstracts, seeing what was coming. What do you think is the most exciting things being presented here? Any data that you think has the potential for?
Yeah, so I think that a lot of the CAR T data is really interesting. There's follow-ups for the axi-cell and Tisa-cell data now with longer-term follow-up and demonstrating pretty excellent long-term responses.
I think an abstract that looked at single-agent bispecific antibody as treatment for older patients with diffuse large B-cell lymphoma, a non-chemotherapy approach, showing significant activity, and knowing how those patients are very difficult to treat, that could be a game changer if that's recapitulated.
Yeah, and I really like the kind of the long-term or longer-term data looking at duration of response after glofitamab. That seems to be durable and stable. So I think that with fixed duration of glofitamab, 12 weeks of therapy, that makes really kind of interesting data set to follow.
Yeah, I think it looks like we're going to see a lot more bispecific data that will add to what we have. And then just kind of to conclude here, maybe if each of you could comment on what you're most excited about moving forward in both diffuse large B-cell lymphoma and follicular lymphoma.
I'm interested to see more of the very early and frontline data with CAR T. Either just following a cycle of CHOP or bispecific combinations in the frontline setting.
I guess I'll wear my NCTN stripes here, but I think in large cell lymphoma, we're at a point where we may be using the sequencing clusters that are now apparent and are able to be recapitulated as a way to assign patients to various trials, sort of a basket trial like has been done in solid tumors. And I'm excited about that approach as potentially moving the field forward. And in follicular lymphoma, we're looking at trying to cure follicular lymphoma in patients with low tumor burden disease. And I think with some of the relatively non-toxic approaches that we discussed today, there's a lot of enthusiasm that that could happen.
Yeah, and I agree. I like to really see the genetic clusters that have been, kind of well characterized now, translate into something that can be applied clinically. And I'm not sure that we're quite there yet, but I think it's coming. And then, with that, doing precision medicine, really sort of therapy. Think about the ibrutinib and our CHOP data that were published, not too long ago. Very tantalizing, right, to see whether perhaps that particular, MCD subset or the genetic group, it's really responding well. I think that if those can actually be applied to more of a, a clinical landscape, even in clinical trials, I think that would be good to see.
All right, well, I'd like to thank all of you for this excellent conversation on large cell lymphoma and follicular lymphoma.